It is my pleasure and honor to welcome Professor Mohamed Rela to speak on the next topic, tailored immunosuppression in liver transplantation. Professor Rela is Chairman and Managing Director of the Rela Institute at Chennai. But more importantly, he's perhaps the one liver transplant surgeon, besides being a pioneer in many aspects, who truly straddles multiple geographical regions and has really influenced transplantation globally. Over to you, Professor Rela.
I need to be able to share my screen actually. Thank you, Sanjeev Saigal, for inviting me, and thanks, Dr. Subhash Gupta. My talk is on, I'm still not able to share my screen. It says the host has disabled you from sharing screen.
It's enabled, sir. Please try once again.
Yeah, I've got it now. Thank you. And thank you for this title, Tailored Immunosuppression. And I just want to say, I think in today's world, I think every clinician and transplant hepatology, in fact, practices tailored immunosuppression. I don't think it's any more protocol-driven immunosuppression. We all make major changes to immunosuppression on a daily basis, depending on really the immunological status of the patient, the nutritional status, renal impairment, which comes even post-transplant, septic episodes of fever. I think it very much is tailored to an individual patient. And I think protocol-based immunosuppression is a thing of the past, I think. But it's important to understand how we started. I think with the start of immunosuppression, if you look at before the cyclosporin era, all the focus was on really avoiding graft loss due to rejection. And with cyclosporin also, rejection was still a huge problem. It was only really when tacrolimus came into use that we slowly started to forget about graft loss due to rejection as a problem. So if you look at the cyclosporin era and the tacrolimus era, it's only during the tacrolimus era you're really bringing down the incidence of steroid-resistant rejection to probably less than 5%. And now we are starting to think about the long-term effects of immunosuppressions and the complications associated with immunosuppressions. So I would say the awareness of tailored immunosuppression has been there probably for the last 15, 20 years. And every clinician really tries to do the best for the patient. And I think in the liver, it's even more relevant that we don't over-immunosuppress patients because the graft loss due to rejection over a period of time in liver is much lower than in other solid organ transplant, and chronic rejection has not been any more a major problem in liver transplant. And the biggest advantage, you may have any number of immunological reasons why liver is a privileged organ. I believe that the regenerative capacity of the liver's ability to regenerate itself after injury, which doesn't happen in other organs, is probably one of the most important factors that allows for really absence of graft loss in the long period of time. But nevertheless, really, if you look at the outcome of long-term outcome of these are liver transplanted patients, there is clearly a reduction when you look at 20-year survival of these patients. There is a reduction in survival, and you'll be surprised to see that there is a 36% survival gap compared to the general population for liver transplant patients when you match them for age, sex, and comorbidity. So there is a significant reduction in survival in post-transplant patients. And the interesting aspect of this study is, I mean, until I saw that, I was quite surprised. We always say that in the liver transplant recipients, most of the graft loss or survival is within the first year. And once they survive first year, the 3-year survival. And once they survive 5 years, the graft is almost a horizontal graft over a long period of time. And I find that that is not true anymore. I think the graft is somewhat stable. I mean, the survival curve drops in the first year, as you see, and then it is somewhat stable for about 8 years. And following 8 years, there is a rapid drop in survival rate in transplant patients, the liver transplant patients. And you will see that most of the cause of death after the 8 years is non-liver related. Liver-related complications are also significant causes. There may be fibrosis or recurrence of portal hypertension in children. But most of the non-hepatic causes, most of them, 2/3 of the causes due to non-hepatic causes, and they are malignancy, cardiovascular events, and renal impairment are probably the main causes. And all of this is in fact related to a protracted exposure to immunosuppressive agents. So I think it's become necessary that we do look at modification of immunosuppression for the benefit of the long-term survival of the patient, rather than really the short-term benefit. And it's very clear. It's the other side of the story is we worked hard to avoid rejection. I think now we know that 1 episode or 2 episodes or 3 episodes of steroid responsive rejection is not bad for the patient. In fact, the long-term outcome of patients who have had steroid responsive rejection is in fact better than patients who never had an episode of rejection. So that's an interesting statistics, and therefore it is important that we don't try to avoid rejection. I think mild or moderate rejection, which is responsive, is in fact good for the patients in the long term, as people believe that it may be one of the factors for long-term tolerance for patients. And again, this study shows exactly the same. In fact, the worst aspect of high immunosuppression is the long-term risk of cardiovascular risk and malignancy and renal impairment risk. So what does an ideal immunosuppression schedule look like? I put there as a schedule because it's not always a single drug, because if you use a single drug, you may be using a higher doses or higher levels of the drug. Maybe combination is something we still need to think about to have them at a lower dose. So it's something which provides a stable graft function with reduced risk of severe rejection or steroid-resistant rejection is what we need to aim for. Mild or moderate rejection, in fact, is not a bad thing. Has minimal toxicity profile, and it has minimal long-term complication and an easy dosage schedule, like we saw Agrograph, where there can be a good compliance would probably be the best immunosuppression schedule. Now, Jeff McCogan from Australia wrote this review. This is about 6 years ago, where he said that there is no such thing as a protocol immunosuppression in liver transplantation. Everything has to be really tailor-made for an individual patient, and it is a balancing act. Which needs to be really thought about on a daily basis, and one needs to think about metabolic risk factors, reducing calcineurin inhibitors in renal function, and mTORs in malignancy. And this is really what we are looking at, and I think most of you would agree that nobody follows a strict protocolized immunosuppression protocol. And when we look at the survey, I mean, there has been some idea of having a steroid-free immunosuppression single drug such as calcineurin for immunosuppression, but then this survey by SRTR clearly shows that almost 60 to 70% of all transplant programs start off with a 3-drug regime with calcineurin, with MMF and corticosteroids, but corticosteroids are stopped over a period of 3 to 6 months, and the MMF is stopped probably over a period of 2 to 3 years. Now, some of these slides may be a repetition because the whole conference is about immunosuppression, and there have been talks on cancer. There has been talk on renal sparing immunosuppression as well, but I'll just summarize really a few more slides and stop my talk. So in cancer, there has obviously been drugs which have an anti-oncogenic effect, and there are drugs which actually stimulate cancer growth. Obviously, calcineurins have been shown to actually affect progression of or recurrence of tumor. On the other hand, the mTOR inhibitors have been beneficial in patients with cancer. And the evidence for tacrolimus has really been very clear, and it's also dose dependent. When the trough concentrations have been more than 10 nanogram per milliliter, the risk of HCC recurrence have been almost threefold in this study. And also when the trough levels are between 7 and 10, by running the tacrolimus lower, you can actually halve the HCC recurrence in the post-transplant setting. And that holds good actually if you use, in fact, everolimus, add everolimus to your immunosuppression. And that again has shown a significant reduction in the recurrence rate of HCC for tacrolimus alone, with 13% recurrence versus everolimus at 4.1%. So everolimus has very clearly been shown to be beneficial. But do we need to then start every patient with HCC on everolimus is a question that we need to think about. And I think this study from Professor S.G. Lee is the lead author of this study, which compares two prospective randomized studies. It's a pooled analysis of the Eastern versus Western study. In the West, it's all been DDLT, and most patients have been within Milan criteria. And in the East, it's been mostly Asian centers and LDLT centers. And most have been, there is a significant increase in number of patients outside Milan criteria. And they have the pooled analysis of everolimus with tacrolimus or tacrolimus alone. They also look at renal impairment. When we look at cancer alone, it was beneficial in patients outside Milan criteria. So if we are following outside Milan criteria within UCSF, there is a clear difference. In the mTOR arm, it's 5.9% recurrence in comparison with 23% recurrence in the tacrolimus only arm in patients outside Milan criteria. So to summarize, for HCC, CNI minimization alone works. Not running tacrolimus levels of over 10 is beneficial in reducing the risk of recurrence. And if you're transplanting patients outside Milan criteria, obviously everolimus has a role. But if you get a post-transplant recurrence, whether you would want to switch to everolimus, the advantage is doubtful. I think you need to combine sorafenib with mTOR, or you need to have some other strategy for these patients. Renal impairment, I'm sure, has been discussed previously. Yesterday's talk, you had renal impairment there. Tacrolimus obviously is toxic, and it causes sometimes irreversible or reversible vasoconstriction. And this is very much a dose-dependent complication, and it also causes hypertension and hypokalemia, which can all be hypertension responsible for renal impairment as well. I think handling tacrolimus is very important, and it's also a fact that the tacrolimus-induced renal toxicity is much more in the liver and intestinal transplantation compared to other solid organs such as heart and lung transplantation. Perhaps these patients, many of them have renal impairment even before going for surgery. Now, how do the minimization strategies for renal impairment patients? So one needs to think about either reduced dose of tacrolimus to start with from the beginning, or CNI delay in the initiation after 5 days or 6 days by using IL-2 antagonists. And this is what most people have done. Can we think about not having CNI at all? I don't think that's been an option. It's not been an option even in the long term, I believe, for renal impairment. If you have CNI withdrawal completely, the risk of really biopsy-proven acute cellular rejection is much higher when you use mTOR alone, and therefore it is not safe to withdraw CNI completely. And I've certainly seen in the early days of MMF introduction, when we used to really lower the dose of tacrolimus and start MMF, and there have been instances where people have actually withdrawn CNI and substituted with high doses of MMF, and there have been graft loss associated with it. I think CNI, even in a small dose, is essential for avoiding rejection in these patients. And there is certainly CNI minimization has benefits either in the form of delayed introduction or a low dose introduction. And in this study, you clearly see that the renal impairment, or a 30% increase from the baseline with tacrolimus normal dose, it's about 42% compared to 24%. With respect to really tacrolimus, this study, which has CNI alone, or tacrolimus with mycophenolate, or delayed entry of tacrolimus after IL-2 receptor blockade. When you look at the three groups, in fact, the delayed introduction of tacrolimus has fared even better than the lower tacrolimus dose right from the beginning of less than 8 nanograms. I think this has probably now become a standard practice in patients with renal impairment to have a delayed introduction of tacrolimus with IL-2 antagonists being used. I think I will go on to really the use of everolimus in liver transplant patients, and this is the RESPECT study, which we saw. There have been some comments about the RESPECT study because the levels that have been maintained have not been very uniform in these patients. The aim was to have a tacrolimus level of less than 8 nanograms, but a number of during the period in most of the patients, they have not really achieved the levels that the study was aiming at, and there has been some criticism about this study. And now coming to, this is what we talked about earlier, was a reduction in the tacrolimus dose as well as delayed introduction, but now there is also the opportunity to use everolimus with a low dose tacrolimus in order to improve renal function in these patients. And one of the other aspects that is not really focused on well is that even NASH patients who have normal renal function have a potential for renal impairment in the post-transplant period. And here you can see that within 2 years, 30% of NASH patients had stage 3 CKD as compared to only 8.3% of non-NASH patients. And therefore, one needs to really think about NASH patients as well as a potential for renal impairment in the post-transplant period. Again, in the NASH patients, there is also a possibility that one needs to think about mTOR inhibitors with low dose tacrolimus, and because that actually reduces the incidence of cardiovascular events. And here you can see that TAC elimination, which I'm not sure is possible, reduces the cardiovascular events to 2.2%. As compared to tacrolimus, which has a major cardiovascular event of around 7%. Just a couple of slides about immunosuppression in children. They are different, and children really don't need very high levels of immunosuppression compared to adults, particularly if their transplants are done at a very young age. And also we found that in the early days in the comparative study between tacrolimus and cyclosporin, we were maintaining tacrolimus levels of about 15 nanograms, and the incidence of PTLD was extremely high. It was almost around 12 to 15% in the early days of introduction of tacrolimus, so indicating that what was okay for adults at that level, I mean, it wasn't okay even for adults, but they didn't have much PTLD. Children had a much higher incidence of PTLD, and therefore, in general terms, children require much less immunosuppression than adults. And there has been a lot of talk on steroid-free immunosuppression, not even to give them steroids during the immediate post-transplant period. And there have been suggestions that steroid-free immunosuppression is beneficial for growth and development in children, and there have been some study, but I don't think many people still avoid steroids completely. And where I've come from, really, King's, they still use a small dose of steroid in the long term, and I will show you that there has been some benefit out of it. So these are the studies where they have avoided steroids completely and have demonstrated that the episodes of acute rejection is not very high compared to the steroid included protocols. Now, one of the aspects of steroids in the post-transplant setting, I know most of us discontinue steroids after 3 months or maximum after 6 months. There has now been a lot of talk on chronic rejection and graft fibrosis in the long term, and this is particularly relevant in children. And there have been some suggestion that using a small dose of steroids reduces the incidence of graft fibrosis in the long term. And also the graft fibrosis without inflammation, even though you see no inflammation, may be a sign of or immunological, or maybe a sign of chronic antibody-mediated rejection. So really the argument is still there whether one should be using steroids or no steroids in the long term for children. Thank you very much. And this is my last slide to say that really a tailored immunosuppression is what we practice on a daily basis. I don't think it's a new concept anymore. Good immunosuppression is something which maintains a stable graft function, minimizes severe rejection in the early period, and avoids toxicity in the long run, and then prevents the risk of disease recurrence in the long run as well. Thank you very much.
Thank you very much. Are there any questions?
So, Dr. Rela, it's absolutely fantastic talk, and I know you like this, conceptual lectures, and I really enjoyed that. Now, tell me, we are very much into a stable phase. Generally we understand how to act now, what to give. So, what is the next, couple of years or maybe a decade? What are we going to look into it? Is it a genomic profiling of patients, or something that are more targeted to a patient when we start the immunosuppression? Is there a next step which you can visualize as a visionary?
I don't know. I think don't you have a talk on that next or something like that? I think genomic profiling is something that may be coming in, and finding out how they metabolize tacrolimus to decide on the dosage of tacrolimus is all probably. I mean, it's all. Even we are really doing some of those aspects. But I don't think we have incorporated that into really the clinical practice yet. I'm sure all of these developments will be there. I mean,
yeah. The talk which I have kept actually is Dr. Jalal, who would be speaking on biomarkers for rejection in liver transplant, which is going to be very exciting to. That will be like a very specific thing. And but I think that probably the time is coming that we need to go move a step ahead of the routine tacrolimus and everolimus all, and then see how better we can improve the. But what you said is absolutely fine and fantastic. Actually,
what I mean by tailored immunosuppression is not really. Most people think about specific aspects or renal impairment or malignancy or children, but I think the tailored immunosuppression really is an art. I think that I can see the M.I.C.E sitting there who will tell you what we do on a day-to-day basis in patients who look very sick, in patients who look septic. We comfortably withdraw tacrolimus completely and not worry about. We know such patients are not going to reject. I think it's an art actually, and it requires some element of experienced clinician to boldly take decisions like that, to completely withdraw immunosuppression for a week to rescue the patient. And then the patient looks septic and the bilirubin is going up, and we don't know whether this is really graft dysfunction due to sepsis or whether rejection is come into play. I think these are very difficult decision making, which only comes with experience. I don't think you can have a protocol or you can have really written algorithm to do what we have to do in an individual patient. I think everything that we follow these days is a tailored immunosuppression rather than protocol-driven immunosuppression.
Absolutely.
Dharmesh,
the challenge with the CYP profiling is that we do not know whether it would follow the donor pathway or the recipient pathway, and plus also the fact that the CYP enzymes are also expressed in the intestine. So even though it's all very exciting, and we have a lot of papers and publications on the fast and slow metabolizers, but we still do not know, like you said, whether it would be clinically relevant or not. It just reminds us of the hepatitis C days, when the recipient interferon lambda genotype and the recipient and the donor's liver genotype, they used to decide as to what is going to happen to interferon based treatment. So I think there is still some work to be done over there.
I think the hepatitis C days were probably the most tough days in the post-transplant period.
Oh, absolutely. So I think that's why what we saw by way of the renal outcomes in liver transplant was largely driven by hepatitis C fear. So people did not want those patients to reject, and that is why we ended up using so much of immunosuppression in that cohort of patients. And also, like I said yesterday, the influence of the renal guys, they always wanted high trough levels. They still do. And because we picked most of our immunosuppression knowledge from them, and that's why in early years we used to have patients running on very high TAC levels, whereas now we know that even in the first month 5 to 8 would be good, because the patient is also on a multitude of other drugs.
I think the Indian patients don't require that much immunosuppression.
Absolutely.
Because in the UK we'll be starting them on 3 milligrams BD. Running at 10 nanograms, and here we start them on 1 milligram BD. It's unbelievable how low an immunosuppression we are practicing here, and rejection is still not a problem. I don't think graft loss due to chronic rejection or steroid-resistant rejection is that big a problem, even with such low immunosuppression. But I'm keen on multi-drugs really. Single tacrolimus dose is not what I favor, I think. And the other thing I'd like to ask, Dharmesh, you used a lot of everolimus. Do you believe that a combination of everolimus with tacrolimus is superior to or better? I mean, so I don't think we should use superior in the sense of more powerful immunosuppression. Is it better than tacrolimus mycophenolate? I'm asking you this because I switched a patient who was on tacrolimus mycophenolate in a stable situation to tacrolimus, everolimus, and tacrolimus, and he had a very severe rejection.
Right. So these are two things, and we talked about this yesterday. So first was the fear of using both an mTOR inhibitor with an anti-metabolite, which is what the earlier studies suggested, and that fear is unfounded. So you can use everolimus and an anti-metabolite together, and you will probably end up using lower doses of both, which is better for the patient. So earlier studies all said that as soon as you add an mTOR inhibitor, you take away the anti-metabolite, and that was because of the cytopenias. Now again, if someone is stable on tacrolimus and MMF, one would not want to use everolimus. So what we were trying to discuss yesterday is that the maximum harm that is done by the CNIs with respect to renal impairment happens in the first 1 month. And most studies have introduced mTOR inhibitor only after the first month. So we are a strong advocate of an ab initio everolimus in a cohort of patients whom you know about. So this should be preemptive rather than event-based. So you should know that this particular patient has got this risk profile, and that is why I would want to, lean on the side of a really low TAC and have an everolimus. So the experience with everolimus is now increasing, and we all know that it works very well when somebody has a bad rejection. It works very well in somebody who needs TAC at a much higher dose. So if you were to add even a little bit of everolimus, you would be able to come down on TAC substantially. So I think these are the things to remember. The only con is about the proteinuria and hypertension, and in a very, very small proportion of patients, the dyslipidemia. So these would be the 3 areas of caution, and amongst these, I think proteinuria is the most important.
Right. Thank you, Professor Rela, for a fantastic talk and some very good discussion. With permission of chairpersons,
there are some questions in the chat box, I think.
We have reached a time for your case discussion, Dharmesh. So I can take questions, then your case will be limited then. Because your case is supposed to start now, actually. So I think it's better that we start your case. And I know you are going to generate some exciting discussion